Welcome to the AO Spine Research Top 10 podcast with Myelopathy Matters from Myelopathy.org.
In this episode, we'll be hearing about the number 2 priority, natural history. We hear from spinal surgeons Dr. Jefferson Wilson and Dr. Brian Kwon, and Lady Julia Carter, a person living with cervical myelopathy.
I'm Dr. Michelle Starkey, scientist and director of Myelopathy.org.
And I'm Dr. Ben Davies, neurosurgeon, scientist and founder of Myelopathy.org.
This is the AO Spine Top 10 with Myelopathy Matters from Myelopathy.org. Welcome to episode 2, where we're going to be exploring the number 2 research priority, understanding the natural history, or as the full question states, what is the natural history of DCM? What is the relationship between DCM and asymptomatic spinal cord compression, or canal stenosis? What factors influence the natural history of the disease?
That's right, and that's one of the questions that emerged from AO Spine RECODE-DCM, an international collaboration of people working and living with DCM, which aims to accelerate knowledge discovery that can improve outcomes by identifying the top most important clinical uncertainties such that we can consolidate research energy and resources.
In this series, we're going to be talking to experts from around the world to understand why these questions are so important. And to that end, I should introduce our first guest, Dr. Jefferson Wilson, surgeon-scientist at St. Michael's Hospital in Toronto. And I started by asking him, what do we mean exactly by natural history?
Natural history basically just implies that if we have a patient that we see in clinic or we have a clinical encounter with, the natural history is what will happen to that person if left unattended. So if we don't perform surgery and simply observe the patient over time, what will their clinical course be? Will the patient deteriorate? Will they have worsening in their hand function or walking if we leave them unattended? Will they remain stable and not change very much? Or best case scenario, could they potentially improve if we left them alone? So that's basically what we mean by natural history, is what will happen to this patient if they are left unattended in the way of treatment. And specifically in the context of cervical myelopathy, what will happen to the person if we don't perform surgery on them after they've presented with symptoms or signs of myelopathy.
And I suppose there are a number of factors that sort of play a role in that. So that sort of course will be different from person to person.
Cervical myelopathy is a heterogeneous entity wherein there are a number of unique clinical phenotypes. And while we can parse these phenotypes in a number of different ways, the most simple way to look at these different clinical entities is based on clinical severity. So we know on one hand, there are patients that come to us who are very severely affected with cervical myelopathy symptoms. They may be bedridden or barely able to walk, or may be barely able to use their hands, very disabled. But on the other end of that severity spectrum, we have patients that are actually quite well, and they may have some relatively minor symptoms, but they are able to carry on with life in a normal fashion. They hold down steady employment. They have extracurricular activities. They have a rich family life. So the implications for natural history are obviously very, very different when we're thinking about those 2 different unique phenotypes of patients. On one hand, for the patient who's already quite advanced and has severe myelopathy symptoms, well, we're not as interested in what the future holds for that person if we don't operate, because we know they're already about as severe as they can get, and surgery is really a no-brainer. Most surgeons would operate on a patient that has a severe myelopathy, and in fact, that's what our guideline work formed a few years ago through AO Spine suggests that people and surgeons should do when encountered with a severe myelopathy patient. But natural history really has the most relevance for when we're talking about patients with more mild symptoms, because there is uncertainty about how we should be treating these individuals. And so it's of interest to know what's going to happen to them if we leave them alone and don't do surgery. So this is kind of the nuance of how natural history plays a role depending on the patient you have sitting in front of you.
Why is improving our understanding of the natural history of DCM so important for improving outcomes for these people?
At the moment, just because of where the level of evidence is at and the relatively early stage of inquiry which we are at in investigating this problem, we tend to make decisions in kind of, I would say, almost one-size-fits-all type of approach. But there's really a role to understand on an individual patient level how somebody's going to do. If I can get back to that more mild patient that I'm talking about, and if, for instance, I have a 45-year-old lawyer who's sitting down in my office who comes to me because his GP ordered an MRI scan for neck pain and a little bit of numbness in one finger, and the MRI shows significant spinal cord compression in the cervical spine, and the question is now what to do with this person. So he's sitting in my office, and the crux of this problem and the decision making surrounding this patient is how is he going to do if we don't operate on him? And if we develop ways to understand how he's going to do 5, 10, 20 years out, if we don't do surgery, then this will inform decision making when he's first sitting in a surgeon's office. So the best case scenario for him is that, we have evidence to show that he's not going to get worse if we follow him. So he doesn't have to have a potentially pretty large operation on his cervical spine to prevent him from getting worse. In fact, he can just be left, carry on life as normal. He can be followed closely, but we can tell him with some authority that he's not going to get worse if we don't do surgery. On the flip side, if we had evidence that we could tell this person, there's a high likelihood that you're going to get worse, so we would recommend surgery now to avert, this negative progression and deterioration in your symptoms, that would be also nice to know. So I think the take home is if we have a better sense of natural history, especially if we're able to predict natural history for individuals, we'll be able to best offer surgery to those who need it most, but conversely not proceed with surgery in individuals who don't need it.
So they can avoid getting, this heavy-handed approach of, sort of being rushed into surgery when, like you say, they potentially don't need it at that point. So what would be the worries about jumping in early with surgery? What could be potential deficits that could occur because of that? Why would you be trying to avoid that?
I always tell patients that, the treatment I have to offer isn't like taking a medication or undertaking physiotherapy. It's oftentimes major surgery. And we know that with surgery for cervical myelopathy, there's about a 15% chance of complications, and about 1/3 of the time, those complications are major. And if, in spite of best intentions or, even excellent surgical practices, some of the time these complications are just unavoidable. It's part and parcel with having an operation. And if you're one of the unlucky folks that has one of those complications, sometimes, and this doesn't happen frequently in 2020, thankfully, but sometimes the complication can end up being worse than the disease and symptoms that the patient started with. So this is why the question of whether or not to do surgery for somebody with mild symptoms becomes so relevant, because if you take somebody who's has some numbness or some little bit of balance issue, and they undergo surgery and things go great, and they're able to get back to work in 3 months, well, that's a home run. That's awesome. But there is this unfortunate small percentage of individuals who have a major complication, and that can be life-changing. And their symptoms are worse than where they started preoperatively, and that's everybody's worst nightmare. So that's why we can't just operate on everybody and without a more refined approach to say anybody who has any symptoms in core compression is getting surgery. We have to be more sophisticated than that because we know that sometimes bad things can happen with surgery, even with best intentions and good surgical practice.
So, what is our current understanding of the relationship between DCM and asymptomatic spinal cord compression?
Well, we know that the root of the problem in cervical myelopathy is basically arthritis. It's, just like arthritis can affect the knee joint and the hip joint and the shoulder or the elbow, it can also affect the neck and the cervical spine. And so when arthritis takes hold, usually in an age-related way, and it affects the cervical spine, unfortunately, the associated arthritic pathology can lead to compression of the cervical spinal cord, and then myelopathy can develop subsequently. But implicit in those comments is the fact that most people get arthritis in their neck as we age, and so a lot of people, a significant proportion of the world, if we live long enough, will have spinal cord compression. Only a small percentage of patients that have spinal cord compression due to arthritis become symptomatic and need surgery. Approximately 1/5 of patients may develop some symptoms after presenting without symptoms in the context of cord compression over several years' time. So this doesn't mean that these patients become paralyzed or extremely disabled, but they develop some neurologic symptoms compatible with spinal cord compression. So we also know that the most potent or important predictor of understanding who is going to develop symptoms in the context of asymptomatic cervical spinal cord compression are those who have symptoms of nerve root compression. So they may get a shooting pain down the arm or focal weakness or sensory changes in the arm. And these patients seem to be at higher risk of developing myelopathy-related symptoms as time goes on.
So what exactly is the relationship between cervical myelopathy and subclinical disease onset?
At the moment, we don't have the greatest outcome measurement tools or ways to assess patients with cervical myelopathy, especially in the mild phase of things. This is really where most of the controversy rests and also where the most opportunity rests, because as we chatted about, there's not a lot of uncertainty about how somebody who can't walk, who's in a wheelchair, who can't use their hands should be treated. But there is a lot of uncertainty about how the 48-year-old lawyer who's at the prime of his life, who needs to provide for his family, should be treated in the context of very mild symptoms and a bad-looking MRI scan. And ideally, we can custom tailor a treatment approach to that individual based on how we know their disease is going to play out in the way of clinical trajectory over the ensuing years. And so that's where we need to get to. And that's kind of what a lot of the work my team and research group has been focused on.
So I was wondering if you could explain to us a little bit about the natural history or neurobiology involved in the progression of someone's symptoms from mild or moderate to more severe.
We know that chronic compression on the neural elements is probably a bad thing, especially on the spinal cord. What we think happens is that not only are the neural tissues compressed, but the blood vessels surrounding and that supply the neural tissue are also chronically compressed. And what can occur is that the tissue itself, due to the narrowing and compression of the blood vessels, can become chronically ischemic. And so it almost is, I guess, analogous to having a chronic state of low blood flow or ischemia, or almost like a stroke-like phenomenon that's occurring within the spinal cord. With that comes lower oxygen levels. The cells within the spinal cord don't have the nutrients and the materials they need to function properly, and they slowly start to die. And so with more prolonged compression, that phenomenon increases and progresses. And as the cells within the spinal cord, whether it's the neurons or the supporting glial tissues, die, the neural relay function of the spinal cord itself is impaired, and then the symptoms will progress. And what we see is progression in the myelopathy symptoms, namely problems with hand functioning and balance and walking are really the cardinal features of that progression. We lack definite knowledge about what factors may make one person deteriorate, say, over a decade, whereas a similarly presenting patient, and that's where the whole concept around defining natural history comes from, is understanding that trajectory and how it may differ between individuals, and how we can identify that differing natural history between patients when we first meet them, so we can better tailor treatment.
How will improving our understanding of natural history benefit surgeons like you?
A lot of this is most relevant for the mild patient. When this mild patient who comes to our clinic is sitting there in front of the surgeon, and in a lot of circumstances, this is a younger patient in the prime of their life who is facing a big operation. At the moment, there is some ambivalence, I think, on the side of most surgeons about whether or not we should be taking this individual for a big surgery, which is going to mean time off work, potential for complications, time away from family. So the best situation would be if the surgeon knew at that point which patients did and did not need surgery acutely. Or equipping the surgeon with that knowledge would go a long way, I think, because I got to tell you, it's tough to rationalize doing a big operation with the attendant risks in the face of relatively mild symptoms just on the basis of an MRI alone. So, at least speaking from personal experience, I would like to have greater knowledge that, yes, I need to do this surgery now because in 2 months, this person who looks great now may not look so good. On the flip side, I would be relatively reassured if I see this patient with a worrisome MRI and relatively minor symptoms, and if I could satisfy my own anxiety and concerns about not operating on this patient by having a good piece of evidence or a paper that suggested, if I watch this patient closely, minimal harm will come to them at the acute phase, and I'll just continue watching them and save them this big operation at this point. So I think it would go a long way to helping surgeons shore up, as it were, their decision-making surrounding this particular form of myelopathy. And there are a few other issues. I mean, in 2020, at least in Canada, it's pretty easy for individuals to get neuroimaging, whereas 20, 30 years ago, it was, a 6 to 12-month wait to get an MRI scan. There's greater availability of advanced neuroimaging in the way of MRI. And so just by virtue of the fact that a lot of people have arthritis in the neck, we're seeing a lot more patients referred with more mild stages of myelopathy. And so it's increasingly becoming pertinent. And I think this is why there's a greater push on the research side to try to sort out what to do with these folks.
So what would be your recommendations for answering priority 2?
I think we need a proper study. At the moment, we tell patients that, presenting with myelopathy symptoms, that there's about a 30 to 60% chance they may get worse over the next 3 to 6 years. And of course, this is a very imprecise estimate, and there's this substantial room for improvement. My, recommendation is a rigorous observational study wherein we take patients, especially on the milder side of the disease, and we watch them carefully. We perform sophisticated tests at the outset, and those would include advanced neuroimaging, tractography, microstructural magnetic resonance imaging, variety of serum blood biomarkers, as well as sophisticated hand function and walking tests. And then we watch these patients over time, and those that deteriorate, of course, will receive surgery, but those who don't will continue to be followed. What we'll be left with at the end of this is not only an understanding of the rate at which patients deteriorate, but also the predictors of those who are likely to deteriorate or have a more untoward disease trajectory. And in elucidating that, we'll then be able to sit in the consultation room with a patient that presents de novo with relatively mild symptoms and say, yes, Mr. Smith, I think you need surgery. At this point, even though you have mild symptoms, our data suggests that you're going to get worse quite quickly and we need to intervene while we still can. Or alternatively, no, Mrs. Jones, the tests we have show that although you have mild symptoms, you're unlikely to progress at a rapid rate, and we'll just keep watching you until your symptoms dictate otherwise. And this is really eminently possible, and I do think within a decade we'll be at this point.
So do you think you got a better understanding of the natural history, or what the natural history is, Michelle?
Yes, definitely much clearer now. I definitely have a much better understanding of how essential it is to delivering timely treatment for DCM.
Yeah, Jeff really points that out. There's lots of uncertainty there. The trajectories are variable, uncertain, unpredictable. In fact, I was recording a symposium for NAS for this project, actually, and one of the professionals on that symposium talked about these sorts of patients being clinic crashers, because you have to spend so much time counseling them around what might happen. And there's so much uncertainty, so much unknown. It makes that conversation really difficult and very long. There's just so many questions that often don't have perfect answers.
Yeah, absolutely. And I think in particular, this is an issue for people with mild myelopathy that won't be seeing these big changes in their behavior, their symptoms. And I think Jeff makes the important point about the factors that need to be taken into consideration when deciding whether to have surgery or not. And I think, his example of the 45-year-old lawyer was a good one. If you imagine this person with mild myelopathy and you're asking yourself, would it be worth it to go through such a risky surgery when any potential benefit to mild myelopathy would be potentially quite small and might not outweigh the risk? And, you have to remember that he has a demanding job, family, et cetera, et cetera. So it becomes quite difficult.
Surgery, unfortunately, does carry complications. The really serious, I guess, life-changing ones to a degree are not that common, but they do happen. And you're absolutely right. In a case where somebody's managing, symptoms are very mild, life goes on, you really do have an opportunity as a surgeon to make things a whole lot worse. And I don't think it's something you would wish to undergo unless absolutely required. And living with that dilemma must be incredibly difficult.
Yeah, I can't even imagine. And in actual fact, this is something I spoke about to Lady Julia Carter, who is someone that lives with cervical myelopathy and also, importantly, a trustee of Myelopathy.org. What exactly was it like knowing that you were living with a disease that might progress to the point of you needing surgery?
Basically, with a lot of denial. There are times when you become obsessed by the illness and by thinking of yourself as an invalid. And then there are times when you just push it away and say, I'm not going to think about that. That's not me. I'm a different person from that person.
It's the type of disease where, the symptoms at the beginning aren't very obvious. So, you're in that position where you're not really sure if it's just you imagining it or whether it is actually something you need to worry about. It must be strange then thinking, well, I need surgery because actually at the moment, it doesn't feel too bad.
Exactly, yeah.
Well, you must have come to the point where you felt, okay, now would be the time where I think I need surgery. So what happened then?
I suddenly had a deterioration and I lost feeling in 4 of my toes and kept falling, and I had a lot of pins and needles in my legs. And that frightened me. I thought, well, I can cope with that. But if something similar happened, the next stage, I wouldn't be able to cope with it. And I don't really want to go there. And I'd been told the orthodoxy is that once you've got damage to the spine, it's irreversible. So I felt the time was now to do something about it.
That's the difficult decision, isn't it? You know, when you're feeling not too bad and you can cope with the symptoms, but that fear of the future and not wanting it.
And the irreversibility of it.
What was your experience of surgery like?
Absolutely nothing to worry about whatsoever.
And had you been worrying about it beforehand?
Well, yes. I mean, the idea that I might lose the ability to speak, the ability to eat, the ability, let alone becoming paralysed. Yeah. Yes, a slight worry, let's put it that way, yes.
However, it ended up being a very positive experience.
Incredibly. And the amazing thing was that I did actually retrieve some of the sensation that I'd lost.
In your case, actually, this was very much your decision and very much you taking control of it, whereas others have obviously been forced into surgery because it's been left for a long time.
Well, of course, that was the other thing, was having seen them and having seen what happened, there was no way that I was going to let it go.
So before you had your surgery, what were the key bits of information that you were looking for or that you wanted to have answered before finally making that decision?
I think about the dangerousness of it, the risk, and the proportion of risk. I'd had one event which may have had nothing whatsoever to do with the condition, but where I was incontinent, and I was terrified after that. And so I think that that was probably the thing that spurred me on.
So, Julia, what would be your recommendations for addressing priority 2?
I think just making people aware of the condition and its non-specificness, really. So that if you've got a combination of these sensations or lack of sensations, that you ought to be thinking that you might have this condition, and that this condition could then lead to something much more tangible. It's a part of the body that I didn't normally think about, and I think most people don't think about. We know about our muscles and our bones and how they all interrelate. But something that's affecting your nervous system, I think, is a bit remote for most people. And although once you grasp the idea, it's quite simple, it takes quite a while to grasp it and to realise the awful inevitability of it. And of course, the age at which you're diagnosed makes a huge difference. So at my age, I was probably diagnosed at the age of 70. Well, it's not much difference between having myelopathy or just being old. Whereas if you were diagnosed with it at 40, it would be hugely different. And I think that's the main problem, really, is to look at younger people and what the impact is on younger people, both in every way, financially as well as everything else. What I'd like to know is what I can do to help myself. Does anybody know exercise? Is there some food, a diet that might be helpful? Does sleep help? I mean, there are all sorts of things like that.
So I think what really came out of Julia's interview for me was this uncertainty when she got her diagnosis and not knowing what was going to happen to her next.
Yeah, it's very powerful to hear, how incredibly difficult it is to be in that situation. And Julia really highlights how subtle the early experiences are. She second guesses herself, questions whether this is a problem or is not a problem. And lots of those subtle symptoms are really underappreciated by healthcare professionals today.
Yeah, and she also talks about wanting to help herself more. So, for example, what can she eat or what exercise can she take, etc., that can perhaps influence her experience of DCM. And presumably getting to the bottom of this is all part of understanding natural history.
I think so. And I think you hit a good point there. This is about information collectively for both the surgeon, healthcare professional, but also the person living with myelopathy, because together we want to arrive at a treatment decision which is appropriate, confident, right for that individual. But of course, how do we get there? How do we get that information? Well, this is one of the questions I put to Dr. Brian Kwon, Professor of Orthopaedic Surgery at the University of British Columbia and Chair of the AO Spine Spinal Cord Injury Knowledge Forum. And I started by asking him why he felt this was such a critical research priority.
The surgical community recognizes that this is a major area in which knowledge is lacking. And I think some of the great work that you and Mark have done have really highlighted how common this condition is, and that it exists out there in the community in often a very undetected manner. And I think one of the real challenges that we all face as surgeons is what to do with individuals who we're evaluating that have spinal cord compression and either no symptoms or very mild symptoms that are probably mild enough that they really don't see a major impact on their life and aren't necessarily really anxious to undergo a major surgical procedure for. And herein lies a real decision point that I think we all struggle with, which is to say, what should we tell this individual? What do we know about what is going to happen to them over time? And I think that, it's one thing to be able to say, well, we are going to just try to follow you closely. But it's quite another to really be able to inform that individual about what we really expect is going to happen. And that plays a huge role in surgical decision-making. It plays a huge role in what we advise our patients to actually do. And I think this remains really one of the key fundamental management questions. And without really understanding the natural history, I think we'll always struggle with this question of what to tell our patients when they present either with very mild symptoms of myelopathy or no symptoms, but obvious cord compression.
And what is your sort of perspectives in terms of how you approach this clinically today without that evidence that's at your fingertips?
Well, I think that it does mandate a very careful and thorough discussion with the patient about what we do know about what the pros and cons are of surgery, and also what we know about decision making and how patient perspectives play a huge role in that. I think the discussion around what to do next definitely requires engaging the patient and having those discussions around what their perspectives are. Clearly, we meet patients that are very averse to having any type of surgery, and we meet other patients that are on the other end of the spectrum and really just want to have surgery and be done and know that the situation is being dealt with, and people that lie along that entire spectrum. So in my practice, these are very long discussions that we have to have with patients about what is known. And I think we're populating some of that, but clearly there's still a lot of uncertainty about exactly what we should advise people.
I mean, how might you approach this on a sort of research level to try and answer some of these questions around natural history?
To address something like this, we need to first acknowledge that it's not a study that you can necessarily bang off in a couple of years, and you need to be sort of committed to that process. I think that one needs to have a very good sense of the patient population and how a cohort of individuals could actually be followed for a long period of time, and what the healthcare environment and systems are in place to actually achieve that. And then set in place like a really structured system of defining a cohort and then actually committing to following them over many years. It's not, like an exciting drug trial, right? Like this is just the scientifically mundane task of simply following people closely over a long period of time. Not a particularly scientifically sexy thing to do. But I think that if the research community could really commit to something like that, it would make a huge difference. And actually, the patients are actually very positive about that, particularly in our healthcare system. They feel like, okay, I feel very comfortable that my surgeon is going to, see me back in 6 months, and that I have an invitation to contact his office if my symptoms do change in the meantime. So I think that being a bit more proactive about that will definitely enable us to collect better data longitudinally as we go forward.
So that was a really interesting interview, Ben, and I actually learned a lot of things there. I found it very interesting what he was saying, that although this area of research obviously isn't the most exciting, it's so important actually when you're sat opposite someone with DCM to have this information at hand so that you can give them an idea of, the information and the facts to sort of base their decisions on.
Mm-hmm. I think that's right. And I think he reflects on, you really need to commit time. And this is something that's going to take sort of years of observational data to be able to put enough people together to be able to offer that individual information to that patient.
Yeah, and sort of appreciating that from the patient's perspective, that, the time course is really long. It's the fact that this time course is not a standard thing across everyone. Everyone experiences it in a different way, but it's very interesting and important data that is collected. That's really sort of the point, isn't it, of this whole exercise. There's so many questions that need answering, and all of them, sort of super important. And knowing where to start, is the reason why we've done this process, really. So thank you very much to Jefferson Wilson, Julia Carter and Brian Kwon for joining us today. The podcast was researched by Elizabeth Roberts and produced by Carl Homer for Cambridge TV. There's lots of information to be found at www.aospine.org/recode.
Thank you for listening. We'll be back next week for the next item, number 3 in our top 10 research priorities, forming diagnostic criteria. Don't miss it. Why not subscribe on your favourite podcast app so that you don't miss an episode? Until then, goodbye.